Hey, what's up, guys? Today we're going to discuss two interesting things: non-STEMI versus STEMIs. So today we're going to figure out the difference between the two, and we're going to talk about how to differentiate them. So let's get into the action. Hey, what's up, guys? Today we're going to get back into it. We're going to be talking about non-STEMI versus STEMI. A lot of people ask about this, and they have trouble sometimes in the field diagnosing between the two and kind of understanding the difference. So these are all encompassed under something called acute coronary syndrome, and we're going to break that down. A lot of people have seen these very difficult decision trees that start off at the top and say yes, no, yes, no.
With all due respect, what the fuck are you talking about?
Exactly my thought every time I see one of those decision trees. Let's get into this. Let's look at this. Let's make it real simple. This is what we talked about. This is your umbrella term for several groups of disease processes that all revolve around reduced blood flow to the heart. So this ranges from a minimal blockage that causes some discomfort all the way to full-blown blockage. So we know that when blood cannot flow to the heart muscle, that the heart muscle becomes damaged, and this can be a permanent damage if left untreated, and this can be fatal too. This is one of those things we need to take serious, and we need to educate our patients on how serious it is. So if we break it down, acute coronary syndrome breaks down into three pieces. Our focus today is going to be NSTEMI versus STEMI because I want you to know the difference in the two of them. But I also want to talk about unstable angina because it is part of ACS algorithm. So unstable angina is basically when there is a blockage to the heart. It's a smaller blockage and it's not severe enough that it causes any kind of cell death or ischemia to the heart tissue. This is not considered a heart attack, even though they have chest pain or they have some type of symptoms that go along with it. These folks, if this is something they've been dealing with before, they know what makes it better. They know what medications they can take, or they know what to do to kind of help with that. And if it's not kind of in their normal realm and things don't seem right, this is something that is always could evolve into something more. So it's something they need to take serious, but it's also the most kind of entry level to acute coronary syndrome as well. So when we move over to NSTEMI, this is kind of where it progresses on. You have a blockage, but this is considered partial blockage of an artery. NSTEMI standing for non-ST elevation myocardial infarction. So with these guys, they could have symptoms that were easily as severe as a STEMI, and they could feel the same way, but they may not necessarily show up the same way as far as diagnostics. And we're going to talk about that and how that works. This is still considered a heart attack, but this is not the most severe type of heart attack. And then finally, when we go over into STEMI, this is the most life-threatening part of acute coronary syndrome. So this stands for ST elevation myocardial infarction. So we think of these guys as a completely blocked artery to the heart. They will be the most symptomatic usually. These could easily turn into a life-threatening event if left untreated. And then sometimes even with treatment, they're pretty sick folks, and their symptoms and the kind of downfall of all the things that happen that go along with this can be really severe to people. So, things to remember here, if you don't know this already, when we talk about ST, when we talk about NSTEMI or STEMI, what does the ST mean? So this is the specific portion of a heartbeat tracing that you would look at on an EKG. What we do when we look at the ST portion of this is there are folks that have ST elevation. this can kind of give you a quick diagnostic look of how severe their heart attack is, and also depending on what leads you see elevation in, gives you some direction as to where the blockage is on the heart. So the other part of that, what does the MI mean? So myocardial infarction is what it stands for. Myocardia showing you where the location is, so we know it's a heart muscle. Infarction standing for the action of cell death, so we know we have the heart tissue dying. So let's take a look just a little bit quicker about the ST segment so you understand it better. An EKG tracing, sometimes when you look at it, is very confusing for people, and it doesn't have to be that way. So on here, I'm showing you a complete heartbeat on an ECG tracing, and there's lots of letters and lines and stuff. But if we break this down and you go step by step and look at the diagram I've got next to it, because this is going to help you. Remember, this is one heartbeat. You have a single line and you have a couple notches on that line. So what do those things mean? So the first thing you see is that P wave. Look over there on the heart diagram. Your P wave is your atrium, your top two chambers. When you see that bump, that's where they're squeezing. They're squeezing that blood down to the bottom. And then you have a PR segment, which is a flat line. That's rest. Nothing's happening there. Your QRS, look how much bigger that is. Well, where's your QRS on your heart diagram? That's your two ventricles squeezing at the bottom. Why is that line so much bigger? Look how beefy those things are. They're way more muscular down at the bottom. Plus, your ventricle is responsible for pushing blood flow through your body. So it's got to be pretty strong. Then you have that ST segment. This is the one that we keep talking about all the time. Whether it's elevated, it's not elevated. What is a ST segment? Well, let's look at it here. So your ventricle's just squeezed when you had your QRS complex. Your ST segment is a flat line on a normal tracing. This is supposed to be where your ventricles have squeezed. They have relaxed now. So this is a time where nothing should be happening at all. So it is a rest period, and then you have a T wave behind it. What does the T wave mean? Well, T wave is simply that muscle tissue recharging and getting ready to do its job. It's going to beat again. So this is just the kind of repolarizing or recharging of that tissue. So when we look at our ST segment, this is normal. This is the way it's supposed to look. When we go to the next one, we're going to start looking at elevation, and that's going to be an abnormal segment. And this is kind of our clue as to what kind of damage we're looking at. All right, guys, now that we've talked about some of the basic stuff, so now what I want to do is I want to show you a couple examples of some arteries that are what we would consider non-STEMI type arteries. Some that are partially blocked or partially occluded, and these are going to be occluded by plaque on the wall. So over years and years and years, there's a buildup of plaque, cholesterol, and these things, as they go along, they start sticking to the walls of the vessels. And this usually takes a long time. This is not something that happens overnight by any means. So what happens is they'll go through, it'll stick over time, it'll grow and grow and grow. As you can see in some of these pictures, over time, the lipid core or the center of it will get encapsulated in by a fibrous, like tougher outer shell by it. So the concern is over time that grows and grows and grows, but what happens as it grows, it gets thinner. So you can keep filling it, but that tough outer shell continues to get thinner as it grows on the inside. So that's what becomes dangerous. And usually that's what takes us from going from a NSTEMI type vessel to a STEMI, is when we have a rupture. So the next one, what we're going to see is, we'll switch it over on the screen, is we're going to see a vessel that now has this large lipid capsule that's blocking a pretty good majority of the artery. And when it ruptures, what happens? Well, that rupture opens up And what happens is the body's response is, hey, I need to fix that. So, who in the world has never went out on their motorcycle, gave it the beans, did a full send over a jump, and landed on the wrong side of the other side? Exactly. Everybody's done it. What happens when you do that? You come out with bruises, scrapes, bleeding. Well, what happens to those scrapes after a day or two? Well, you get a scab. That's the body's response. You're bleeding. I need to scab it over, give it a tough shell. What's going to happen when that vessel does the same thing? It cracks that fibrous outer layer open, and it releases those coag factors into the bloodstream, and its body's response is, I need to fix that. What's it do? It creates a big blood clot, just like it did on your knee after you got off your motorcycle wreck. And now this big clot that it's created has occluded the whole artery. So now you've essentially shut down the whole flow downstream past that clot. These are serious. This is where it gets rough. These are where you're going to start infarcting that heart tissue downstream, and that tissue is going to die if it's not corrected soon. So here we've got signs and symptoms of both NSTEMIs and STEMIs, because remember, the symptoms can be the same for either one. We generally think STEMIs see more severe symptoms than non-STEMIs, but they both can have the same symptoms, so it's not really a deciding factor between which is which. What is important here is that men and women don't always suffer the same symptoms. Men are more traditional symptoms, that crushing chest pain, sweats, nausea, shortness of breath, pain that radiates into the back or the neck. Women are a little softer on their symptoms. They don't generally have crushing chest pain. They may have the more of the reflux feel or lightheadedness or fatigue. They're just harder to diagnose based on symptoms alone. And it may not come on as sudden as men's as far as how fast they hit. So I just want you to be aware of what the signs and symptoms are. That way, as we're moving forward, this will help you differentiate. So when we're talking about what do we use to diagnose? What are the pieces that we use? Well, we use lab work. We're going to look at troponins. That's a huge gold standard for looking at chest pain and coronary syndrome. 12 lead EKG is going to give us a good picture of what's going on from all directions of the heart. A big one, if the patient is stable enough and is in a situation that they need to go to the cath lab, that is the best option, because sometimes we have all these clinical pieces, but it doesn't give us the full answer. Sometimes the best and only way to really get down to it is to go in and have a heart catheterization, where they go in and they can look at the actual arteries from the inside, and they can use contrast dye to shoot and see where the flow is great, where it may not be great, and that's a place where they can fix it at the same time. So those are your kind of big diagnostic pieces. Yes, you can do a chest CT and MRI, cardiac MRI. Those are all good, but those are kind of process time. Like, they take a little bit more time. So when you're in the zone and you need to know then, those are your biggies. Your heart cath, your labs, your EKG. Those are going to paint a pretty dang good picture for you as far as what you need to know. All right, guys. So now we've seen the inside of a coronary vessel on an NSTEMI versus a STEMI, and we've seen how this progresses and how this happens. This is how now you've seen the NSTEMI translate into a STEMI and all the pieces that go along with that. So that's all good and great, but now clinically, what the heck are we doing? Like, how do we decipher it now? So this is the easy part. We're going to look at just a couple basic pieces of information, and that's going to be able to tell you everything you need to know to differentiate between the two. Let's do, number one is obvious, ST elevation. The name gives it away. Non-ST elevation is an NSTEMI. ST elevation is a STEMI. Doesn't get more straightforward than that. But look at this picture of this 12 lead I put up here, because sometimes you'll hear people say they have a tombstone ST elevation. Well, that term, as you look at the picture, if you've never heard it before, it makes a lot of sense because the ST segment now does look like a tombstone. And it puts you in a, oh, you know what I'm saying. That's a bad place to be in. Tombstones never turn out to be a good thing, not even on Halloween. So, what's the next one? Second, we're going to look at troponins. Your STEMI patients, positive troponins. NSTEMI patients, positive troponins as well. They're both going to have it. So that doesn't really help you differentiate a lot. Remember, troponins are going to be one of those things. You may not see them initially, but you may see them on a second draw a couple hours later or a third draw a couple hours past that. Signs and symptoms, that's another one. So both your NSTEMI and your STEMI patients, they both can mimic each other as far as symptoms. Generally speaking, NSTEMI patients are going to have a little less severe symptoms than your full-blown STEMI patients. Your full-blown STEMI patients, you're probably going to see them in a cardiogenic shock state. That muscle tissue is damaged. There is circulatory pump problems now. These are generally going to be a little bit sicker, but you can see how there's a gray area between the two. They're both going to be symptomatic. One side, the NSTEMI side, generally a little less severe than the STEMI side. Now, one thing I do want you to remember too, remember NSTEMIs can turn into STEMIs like that. So you need to keep track of these patients. Don't dismiss just because they don't have elevation, but they're having chest pain and positive troponins, that these folks aren't sick. Some of the NSTEMIs are going to be the ones that surprise you, and they're actually going to be the ones that turn out to be really sick because they may not get all the attention that a full-blown STEMI gets coming in the door, but it doesn't mean we're going to treat them any less. While we're on the subject of differentiating between them, remember earlier when we talked about unstable angina? Well, how does that go into the mix? Well, remember, unstable angina, it has no EKG changes, so there's no ST changes. Their troponins are going to be negative, but they may still have symptoms. So you can kind of rule those out if you don't have a positive troponin as the labs come back. You don't have a 12 lead change, but you have somebody that has coronary pain, or they have a history of coronary disease and they're having exertional pain or shortness of breath. That's how those guys kind of fall in that category. So that's an easy way to spot out unstable angina. When you go to NSTEMIs, remember, you'll have no 12 lead change on the ST segment, positive troponins, still symptomatic. STEMIs, positive change on the ST, positive troponins, and symptomatic at the same time. That's all. That's all you got to look at. If you can decipher those three pieces, you can tell what's going on just by doing that. Super easy. So one cool part about this, if we look at a 12 lead of somebody that's having a STEMI, we can look at what leads we're seeing a elevated ST segment in, and we can tell by just looking at that what part of the heart is being affected. Where is that clot at? We can tell whether somebody's having an inferior STEMI, an anterior, a lateral, all just in what leads are there and what groups go together, which is pretty cool because if I look at one lead and I don't see a change in it, well, that's kind of like me going out in the driveway and I look at this car. It's beautiful from the front, like it's gorgeous, and I'm like, I might buy something like that one day. Like it's gorgeous, but then I go over and I walk around it, and the whole back end is just smashed in, and I didn't see that from the front. This is exactly how your 12 lead works. From one angle, you don't see any damage to the heart. But if you go over and look at this other lead, now you're wrapping around to the side that's damaged, and you can see a pretty catastrophic difference just in which direction you're looking in. So that's a pretty cool way to think about how the leads on your 12 lead work, is all by looking at different angles. All right, so finally, treatment. What are we going to do for these guys? So let's start with NSTEMIs. NSTEMIs, what we're going to do is we're going to start with medications. So those those patients need maybe nitroglycerin for chest pain. Nitroglycerin does what? It opens the vessels up, it dilates them, and that better perfuses the heart, and more than likely it's going to help solve their chest pain because now they're able to get more blood flow to the heart. Along with that, they're going to need anticoagulants or antiplatelet therapies. This is to help prevent any clotting from happening. They're going to need beta blocker therapy. This is going to help that heart relax a little bit and not consume as much energy, which is what essentially drives chest pain most of the time, is increased workload of the heart. So the beta blocker is going to help relax that a little bit and work a little less hard, which is going to preserve a little more energy. So after all that's said and done, we see where we're at. These patients will probably go to the cath lab. They may not be emergent cases, but they'll go, after the dust settles a little bit. As comparative to your STEMIs, when they come in, they're prioritized to go to the cath lab first. Yes, we're going to give them their aspirins. We're going to give them the morphine for pain. We're going to give them these things as they're rolling through or in the EMS truck as they're coming in, because their biggest goal is to get to that cath lab, and they want to have as fast as a door to balloon time as they can, because the longer this goes untreated, the more damage is done. So primary intervention for your STEMI patients is going to be getting to the cath lab and get in there, see what's happening. If something needs to be opened up, get in there and open it up and let that reperfuse. After that, that's when you're going to sort through all the rest of your medications. You're going to see where you're at with things. Sometimes that's all that really needs to be done at that moment is reperfusing and open that up. They feel a lot better, and then we can kind of focus on long-term goals after that. One last thing I do want to put out there. Sometimes when people go to the cath lab, that's not the end-all be-all. Sometimes we get in there and it's not just one simple blockage. People may have multiple vessels that are blocked. And in that case, the safer option kind of is to pull back a little bit and punt and see where we land, and look into the option of having bypass surgery where they go in and bypass the blocked arteries. It's going to all depend a lot on the person and the situation, but at that moment in time, that might be the safer option than trying to go in and repair multiple vessels over multiple cath lab trips or all at once. It's the safer way to do it. They may need supportive devices like balloon pumps or Impellas to get them through and get them reperfused a little bit better. But that's just the way it goes sometimes. It's not always a drive through, get fixed, and come out the other side looking better. Sometimes we need to step back and say, hey, we're going to have to do something a little bit more in depth. And from that point, then we talk about doing a cabbage and what it looks like from there. All right, I hope you guys had a good time. I hope this helps you kind of sort through NSTEMIs versus STEMIs, give you some real examples of what things look like, and, just have a generalized, better understanding of the whole process. I enjoy having you guys. I love helping you learn new stuff. So stay tuned. We got more stuff coming up. I'll see you guys next time.